Welcome to this explainer. Today, we're taking a pretty fascinating journey to understand the absolute gold standard of medical research. We're going to break down step by step the exact process and architectural design of a randomized controlled trial.
It sounds like a super simple question, right? But how do we really know a medical treatment actually works? I want you to just think about that for a second. Because the truth is, human observation alone can be incredibly deceiving. Our own expectations, our biology, and even just pure coincidence can completely trick us into thinking a totally useless treatment is some kind of miracle cure.
Okay, let's dive into this, because this story is wild. For years, arthroscopic knee surgery for osteoarthritis was incredibly common. I mean, doctors absolutely swore by it, and patients genuinely felt better. But then, researchers actually conducted a trial with a sham surgery control group. Some patients got the real procedure, while others, well, they just got incisions and listened to the sounds of surgery in the operating room. Nothing was actually done inside the knee. And the results? No way around it. Over 2 years, patients who got the real surgery reported absolutely no more pain relief than those who got the fake placebo surgery. It's this mind-blowing historical anecdote that perfectly proves exactly why we need rigorous, objective testing to separate actual medical fact from the incredibly powerful placebo effect.
And that brings us to our definition for today, the Randomized Controlled Trial, or RCT. Unlike historical anecdotes or just kind of watching what happens in a clinic, an RCT is a highly structured forensic tool. It's designed to find the absolute truth. It's an experimental study where investigators don't just sit back and observe, they actively assign the exposure, the treatment, by pure random chance to see what actually happens.
To really wrap your head around this, think about the contrast here. On one side, we have observational studies. That's where we simply watch what happens naturally in a group of people. It's super useful, sure, but highly vulnerable to bias. On the flip side, we have experimental RCTs. Here, the researcher is actively manipulating the exposure, and this active manipulation is exactly what protects us from those sneaky confounding variables. You know, those hidden factors that can completely distort our understanding of cause and effect.
So here is our blueprint for today. We'll be covering 1. The research gold standard. 2. Step 1. Selecting the population. 3. Step 2. The randomization superpower. 4. Step 3. The blinding defense. 5. Step 4. Intention to treat analysis. And finally, 6. Ethics, power, and limits.
Let's kick things off with part 1, the research gold standard, separating fact from fiction.
Let's move to and see how this builds. You see, every perfectly designed RCT follows 4 critical steps. We select the population, we randomize the participants, we implement a blinding defense, and then we analyze the data. Let's start constructing the very first wall of our fortress. Which brings us to part 2. Step 1. Selecting the population, building the foundation.
Imagine you're designing a study right now, right? You can't just test a brand new drug on literally anyone who walks through the clinic door. You have to establish a completely homogeneous or uniform baseline. And you do this by setting some very strict inclusion and exclusion criteria. For example, maybe you only want participants aged 40 to 60 with a specific, confirmed diagnosis, and you're excluding anyone with other chronic conditions. These strict rules act as the bedrock to keep your study base perfectly uniform. It allows you to cleanly isolate the multisystemic effects of the exact treatment you're testing. All right, part 3, step 2, the randomization superpower, the ultimate equalizer. This right here is where things get really cool. True randomization uses pure chance to distribute variables evenly across your treatment and control groups. But here is the absolute magic of it. It doesn't just balance the known variables like age or weight. It's actually the only tool in science that perfectly balances factors we don't even know exist. Think about it. Subtle genetic traits, subclinical metabolic baselines, unrecorded lifestyle habits. Chance just distributes them all evenly. This completely 100% eliminates selection bias right at the starting line.
Now, what's really interesting about this is how we actually execute this superpower in the real world. Basic, simple randomization is basically just a coin toss. But humans are complex, so advanced trials have to use better tools. Take block randomization, for instance. It assigns people in fixed batches. That guarantees the intervention and control groups remain perfectly equal in size throughout the whole trial. Then you've got stratified randomization. If you know a certain trait, like age or biological sex, is going to heavily impact your results, well, you group participants by those traits first, and then you randomize within those subgroups. It is a brilliant way to handle really complex human variables.
But I gotta give you a warning here. A fancy computer randomization sequence is completely useless if the doctor enrolling the patients can just peek at it. And that's exactly why we need allocation concealment. The assignment sequence must be securely hidden away, usually in a web-based system, because if researchers know who's next in line to get the real drug versus the placebo, they might subconsciously steer healthier patients toward the new treatment. Hiding the allocation completely neutralizes that risk.
Moving on to Part 4. Step 3. The blinding defense, protecting the trial.
You've likely heard these terms thrown around before. In a single-blind study, the participant is totally unaware of whether they're getting the real treatment or just a placebo. This is great because it stops their psychological expectations from altering their actual symptoms. But double-blind? That is the ultimate shield. Neither the participant nor the researcher assessing the outcome knows who got what. This eliminates both subject bias and observer bias, meaning a researcher can't accidentally interpret a patient's progress more favorably just because they secretly know they're on the cutting-edge drug.
But here is a fascinating reality check straight from the epidemiological sources, the blinding dilemma. You literally cannot double-blind a behavioral intervention. I mean, think about it. You can't trick someone into sleeping 2 hours longer or eating a strict vegetarian diet without them noticing. Well, unless they're sleepwalking to the fridge, I guess. So what do researchers actually do? They use a single-blind outcome assessor framework. They might not be able to blind the participant, but they can strictly blind the lab technicians analyzing the blood work. That ensures the hard data is still protected from bias.
Let's look at Part 5. Step 4. Intention to treat analysis, the analytical anchor.
So the crucial point is what happens when the trial actually ends, because some people will have dropped out, or maybe they just stopped taking their pills. A pro-protocol analysis says, okay, let's only analyze the perfect compliers who followed every single rule. But the true gold standard is intention to treat, or ITT. ITT mandates that we absolutely must analyze participants strictly in the group they were originally assigned to by chance, completely regardless of what they did afterward.
Now, why on earth do we do that? Because of this one foundational rule. Analyzing only those who perfectly complied destroys the initial baseline comparability generated by randomization. If you throw out all the rule breakers or the people who dropped out because they felt stressed or got sick, you literally ruin the magic of your randomization. You're just left with an artificially motivated, highly biased sample that doesn't reflect the messy reality of the real world at all. ITT is what preserves the scientific integrity of the entire trial.
Finally, Part 6. Ethics, Power, and Limits. The reality check.
And this brilliantly illustrates that we don't use RCTs for absolutely everything, and for very good reason. First off, there are ethical boundaries. We cannot ethically randomize a group of perfectly healthy people to start smoking just to definitively prove it causes lung cancer. That's why observational studies are still absolutely vital for studying the causes of diseases. Second, an RCT requires massive statistical power, meaning you need enough participants mathematically calculated beforehand. If your sample size is too small, you run the risk of a false negative, basically missing a true biological effect simply because you didn't have enough data points to see it.
Well, we've just built the complete architectural blueprint of an RCT. You now know exactly how researchers select populations, how they use the literal superpower of randomization, build impenetrable blinding defenses, and anchor their math with intention to treat analysis. So I'm going to leave you with this provocative thought. Next time you see a flashy health headline claiming they found a new miracle cure, what are you going to ask yourself about how it was actually tested? Look for the blueprint, and I promise you, you'll always find the truth.